Namaste students, today we will be discussing a very important case. The patient by name X is aged about 65 years and he is from the South Bangalore. He is studied till 10th standard and history is given by himself and it is reliable. So the chief complaints is breathlessness and exertion for the last 10 years and palpitation for the last 10 years. Coming to the history of presenting complaint, patient was apparently normal 10 years back when he developed breathlessness, which is insidious in onset, gradually progressive from NYHA class 1 to NYHA class 3. Breathlessness, he says, is associated with the PND, aggravates on climbing stairs and relieves with taking rest. Breathlessness is associated with palpitation and chest pain. It is not associated with orthopnea or any seasonal variation, no wheezing or cough. As in the previous cases which we have discussed, breathlessness evaluation, students, again I want to repeat, breathlessness, whether it is respiratory or cardiac, the two things, orthopnea and PND. He says there is PND. PND is very specific to left heart failure, but he has not gone to till the stage of orthopnea, which is stage 4. And why the develop orthopnea? From interstitial space, the blood will go to the pulmonary circulation, will get congested, and lying down vital capacity is less because of less diaphragm excursion. PND, same two mechanisms, plus respiratory center is less responsive to hypoxemia and less catecholamine support to the heart. So left heart is involved in this case because he is saying there is history of PND. And the insidious onset, gradually progressive. If it is a sudden onset, as I told in the before classes, you will consider pulmonary edema, left heart failure, acute severe asthma, tension pneumothorax, pulmonary embolism and foreign body obstruction. So here insidious onset, gradually progressive. And it is grade NIHA 1 to 4. How do you grade breathlessness? NIHA classification is grade 1, breathlessness due to unaccustomed activity. Grade 2, breathlessness because of the accustomed activity. Grade 3 is breathlessness less than accustomed activity. Grade 4 is orthopnea, breathlessness and lying down. This is NIHA classification. Whereas in other grades of breathlessness, Canadian Cardiological Society method of breathlessness and specific activity scale. Specific activity scale, breathlessness while doing work more than 7 metabolic equivalents. Breathlessness grade 2 less than 5 metabolic equivalents. Breathlessness grade 3 less than 2 metabolic equivalents. And grade 4 is breathlessness at rest or orthopnea. 1 metabolic equivalent is 3.5 ml of oxygen per kg per minute. 752 and then breathlessness at rest. Then you have a Canadian classification of what? Canadian classification. The grade 1 is breathlessness and a severe exertion. The grade 2 is breathlessness on walking more than 2 blocks. Grade 3 is breathlessness with 1 to 2 blocks, less than 1 to 2 blocks. Grade 4 is at rest. 1 block is walking 528 feet. So these two grades of breathlessness for a postgraduate level, they may ask a specific activity scale 7, 5, 2 and at rest, and breathlessness and accustomed activity, Canadian Cardiological Society, more than 2 blocks, 1 to 2 blocks at rest. 1 block is 528 feet. Our patient says breathlessness associated with palpitation and chest pain. There is no history of cough and other seasonal variation. So unlikely a respiratory cause of breathlessness. He gives history of palpitation again along with the breathlessness since 10 years, which is insidious onset and this gradually progressive. He says it aggravates on climbing stairs, lifting heavy objects, released with rest and not associated with any drug intake. And he says palpitation is associated with dyspnea and chest pain. So whenever there is a palpitation, how do you approach a palpitation? Sustained and ill-sustained. Ill-sustained, you get in atrial premature contraction, ventricular premature contraction, ill-sustained, APCs and VPCs, ill-sustained. Then you have sustained. Then a sustained, regular, irregular. A regular sustained, ventricular tachycardia, SVT. Irregular sustained, atrial fibrillation. And positional, Okay, some of the diseases may produce positional palpitation. For example, mediastinal tumors, atrial myxoma, the palpitation will be positional. There are some other etiologies for palpitation. For example, anxiety, okay, a fever, drugs like atropine, cocaine, ethanol, amphetamines, endocrinological causes, thyrotoxicosis, pheochromocytoma. All this can produce a palpitation. A panic attack also can produce a palpitation. Usually, palpitation in a panic attack and psychiatric disorder will be longer duration, more than 20 minutes. It is more than 20 minutes. So, what are the cardiological cause of palpitation? A regurgitation lesions like AR, aortic regurgitation, or mitral regurgitation, or arrhythmias, tachy and bradyarrhythmias. The mechanism of palpitation is sudden change in the rate or rhythm can produce palpitation. The sudden change in the rate or rhythm. And a palpitation is abnormal awareness of one's own heartbeat. That is palpitation. Abnormal awareness of one's own heartbeat. So that's about the palpitation history of presenting complaint. Next, he has chest pain for the last 10 years. He says it is sudden. Then it aggravates on walking and heavy works, releases to taking rest. He says it is associated with sweating, left-sided, pricking type, not associated with any radiation to the left arm, nausea, vomiting. And he says it lasts for 5 to 10 minutes. What could be the cause? What are the cardiological cause, serious causes for chest pain? Coronary artery disease, yes. So first you have to think that coronary artery disease. Other causes, pericarditis. So which are the valvular lesions which can produce chest pain? Aortic stenosis, because of the supply demand mismatch, LVH will occur. They can have chest pain. Aortic regurgitation, because the coronary circulation occurs during diastole. Diastole BP will be very less in ER, so they can have chest pain, especially syphilitic AR. Then pulmonary hypertension, RVH, they can have a chest pain due to either MR, MS. So they can have a chest pain. And in some of the 10% of the patients with MS, they have chest pain, but etiology is not known why they develop chest pain. Anyhow, our patient complains chest pain. Let us see what could be the cause at the end of examination, investigation. Why is there chest pain? So these are the 3 presenting complaints, whatever the patient is having. The negative history, there is no history of syncope. He never gives history of syncopal history. What are the cardiological cause of syncope, serious cause of syncope? Arrhythmias, bradyarrhythmias, which is the valvular lesion which can produce a syncope. Even tachyarrhythmias can have syncope if there is a decreased diastolic time to fill the ventricles. Stenotic lesions, severe AS, MS, mitral stenosis, aortic stenosis can produce exertional syncope. But this patient doesn't give history of syncope. There is no history of fever or weight loss. No history of cough or wheezing, just to rule out respiratory cause of breathlessness. And there is no swelling of legs, there is no pedal edema. He doesn't say there is pedal edema. So out of the 5 cardinal manifestations of CVS, he has a breathlessness, palpitation, chest pain, but no syncope, no pedal edema. Coming to the past history of similar episode of breathlessness and palpitation 10 years back when it developed, for which he went to a hospital and diagnosed to having some heart problem, for which a tablet was given and he was discharged. He is a known hypertensive since last 15 years, for which he is taking the medications and he is not a diabetic. He is taking Ayurvedic medicine for the last 10 years for the above complaint and no history of tuberculosis or previous surgeries. In the past history, especially in these sort of cases, one important thing which you have to ask is past history of rheumatic fever attack. You should not ask a sore throat or a URTA. You won't remember. Everybody will get sore throat or a URTA. How do you ask a past history of rheumatic fever? A past history of rheumatic fever will ask whether the patient experienced a severe painful joint pains, because the pain in rheumatic fever arthritis is such a severe that they'll remember lifelong. So any past history of rheumatic fever to ask, you would ask any past history of severe painful arthritis. Only 50% will remember, like in hepatitis B, how 50% will give history of injection prick for hepatitis B. Yeah, rheumatic fever, not all will give the history of rheumatic fever. 50% will give a rheumatic fever history. Our patient doesn't give history of rheumatic fever in childhood, and in past history is not taking any monthly injections. Okay, is not taking any monthly injections for a prophylaxis. Personal history, he takes a mixed diet, bowel and bladder is regular, no addictive habits, no high risk behavior. Sleep is disturbed because of the PND, probably is having PND, the sleep is disturbed. Family history, he has 2 children, no history of similar complaint in the family members. Treatment history, he is not taking any monthly injection as I told, and he is on oral tablet for palpitation, he says like that. So coming to the analysis of the history, there is PND, palpitation, chest pain. So left heart is failed because there is PND. Why it is failed? Whether due to a coronary artery disease or a muscle disease or a valvular lesion. He is 65-year-old male. Okay. In the addictive habits, one thing I forgot to tell, so the personal history, he is a smoker. Okay. He is 25 years. He is a smoker, and every day he says he used to take 2 pockets of BDs. 2 pockets of BDs every day. Okay, in the personal history. So 25 into 250 pack years of smoking. So a 65-year-old male with a 50 pack years smoking history coming with a chest pain and a breathlessness and a palpitation. The first diagnosis you would think as a coronary artery disease only, ischemic heart disease. So it could be a coronary artery disease manifesting like ischemic cardiomyopathy with heart failure symptoms like him with a history of PND. That is the first diagnosis. What are the other differential diagnoses you can think? Anemia in failure. Anemia per se won't produce unless there is some underlying heart problem. And yes, chest pain. Chest pain unlikely in anemia in heart failure. They'll have breathlessness. Even a classic chest pain is unlikely in ischemic cardiomyopathy. They'll have repeated micro infarction producing with the ischemic cardiomyopathy. They won't give chest pain in ischemic cardiomyopathy. A thyrotoxicosis, a lean person like this with heart failure. Again, he has chest pain, but palpitation, breathlessness, they can have thyrotoxicosis with heart failure. There are some other differential diagnoses which you can think in a male patient like this for the cause of his left heart failure. A cardiomyopathy, or a valvular lesion, or a coronary artery disease. If it is a valvular lesion, which valvular lesion could be the cause of left heart failure? With palpitation. Palpitation, the 2 regurgitation lesion, MR and AR, or if it is a stenotic lesion like a mitral stenosis, MS with AF, could be a possible for left heart failure. 10 years back only he has a manifestation, now he is 65 years, okay, 55. So, what is the usual duration of from the rheumatic fever till the rheumatic heart disease? In the Western literature, they say 20 years from the rheumatic fever to the rheumatic heart disease. But in India, it can be just as early as 1 to 2 years it can develop the rheumatic heart disease after the rheumatic fever because of the virulent strains and repeated upper respiratory tract infection. As early as 6 to 12 years, Brownwell says the children can have a rheumatic heart disease in India. As early as 6 to 12 years. But overall, the globe from the rheumatic fever to the rheumatic heart disease, 20 years is the gap. 20 years is the gap. Yes, this could be a valvular heart disease, rheumatic heart disease possible. These are differential diagnoses. Let us see at the end of examination what is having. This is analysis of the history. Now coming to the general physical examination, patient is conscious and oriented. Anthropometry, height is 177 cm, weight is 48 kg, BMI is 15.33, which is very less, is underweight and malnutrition. Vitals is afebrile, temperature is 98.4 degree Fahrenheit. Pulse rate, this is important. Pulse rate is around 90 beats per minute and it is, students, I will check the pulse rate. You have to always count for complete 1 minute, especially in the cardiovascular system. Okay, you have to complete for 1 minute. You have to count for 1 minute. Yes, so 1 minute over. Okay, the count is 100 beats per minute and it is irregular. Okay, it is irregular. So whenever you get an irregular pulse and it's irregularly irregular, the two words irregularly irregular, you use one for the volume, okay, and one for the rate, okay, one for the rate, one for the volume, okay, use that irregularly two words, okay. And whenever you get an irregular pulse like this, you have to check for the pulse deficit. How do you check for the pulse deficit? Now I'll do again. Again, you count for 1 minute when I look for the pulse deficit. There are two methods. One, simultaneously auscultate and palpate the pulse, or a single person. One person can auscultate, one person can feel the pulse. Because I am single, I'll auscultate, meanwhile I'll palpate. Start. Yeah. So 1 minute over, you have to auscultate like that. The pulse deficit is 15. So what are the two important causes of irregular pulse? One is atrial fibrillation, the other is ventricular premature contraction. One more is atrial tachycardia with variable block. These are the conditions where you get irregular pulse. How do you distinguish a VPC from a AF? This is a standard question which will be asked in the exam. So the differences is, one is pulse deficit, which I checked. Pulse deficit will be less than 10 in a VPC, more than 10 in a atrial fibrillation. If you ask the patient to make exercise, VPCs will disappear, whereas in atrial fibrillation will persist. In atrial fibrillation, atria just flickers, so AV will be absent in atrial fibrillation, whereas in a VPC, because atria and ventricle are contracting at a different time, you may get a canon AVs. You may get a canon AVs in VPC. These are the differences between VPC and atrial fibrillation. Okay, right. The pulse is irregular and it is a high volume. There is no radioradial or radiofemoral delay, and all the peripheral pulses are felt. Especially in atrial fibrillation students, you have to feel for all the peripheral pulses. Okay, especially the brachial, popliteal, femoral, and dorsalis pedis. Okay, in him all the peripheral pulses are felt. Okay, and how to look for the peripheral pulses, I have taken the general examination of the pulse in CVS, so you can go through that video, and in all the peripheral pulses are felt. And why you have to look for all the peripheral pulses in atrial fibrillation? Because there can be a thrombus formation in the left atria, embolism can be thrown to the peripheral arteries, so you have to look for the peripheral pulses in atrial fibrillation. Blood pressure, upper limb 100/70, left upper limb 106/70, left upper limb, right upper limb, lower limb 110/70. So there is no gross variation in the pulse, in the blood pressure recording in all the limbs. Respiratory rate 24 beats per minute, so is tachypneic. Okay, why is tachypneic? Let us see at the end of respiratory system examination why is tachypneic. Okay, and it is thoraco-abdominal. Coming to the vitals, I'll check the vitals and then head to toe examination in this case. So let us go to the general physical examination in him. Okay, and top to bottom, what all you see in this case. Okay, let me look for the pallor. Male nodi, there is no pallor. Kele nodi kanna, there is no icterus. Good. There is no cyanosis. Okay, so he knows there is no cyanosis. Okay, what are the causes of cyanosis? Cardiovascular cause of cyanosis. Okay, so cyanotic congenital heart diseases like phylosteatology, truncus arteriosus, transposition of great vessels, tricuspid atresia. Okay, there are 4 T's which you can remember. Okay, causes of central cyanosis, cardiovascular causes. Okay, right. Then coming to the clubbing, there is no clubbing. There is no clubbing. What are the cardiovascular cause of clubbing? Again, cyanotic congenital heart diseases can produce a clubbing. Infective endocarditis, atrial myxoma can produce clubbing. Lymphadenopathy, there are no lymph nodes. You have to go behind the patient and look for lymph nodes. Okay, and there are no lymph nodes. Let me go behind and check. There are no lymph nodes. Then, pertaining to this case, we are thinking coronary artery disease, then we are thinking a rheumatic heart disease, the valvular heart disease. What all you see top to bottom? For rheumatic fever reactivation, you have to look whether he has any subcutaneous nodules or erythema marginatum. Okay, this patient doesn't have subcutaneous nodules or erythema marginatum. Then markers of coronary artery disease. What are the markers of coronary artery disease? You will look xanthelasma. Okay, xanthelasma. Okay, then diagonal earlobe crease. Diagonal earlobe crease. Okay, he is not having. The nicotine staining either in the mouth or in the hand. I'll he has a nicotine stain. He has a nicotine stain, students, in the mouth. Yeah, so you can see the nicotine stain here and here. Okay, nicotine staining is there. Okay, right. Then in the nails you have to see nicotine stain. In the hands, it's not there. Okay. So pallor, edema, icterus, lymphadenopathy, the pedal edema, there is no significant findings, but he has a nicotine stain. Okay, one. And then obesity, and he is not obese. Okay, and he is not obese. Then arcus senalis. Okay, arcus senalis. These are the markers of atherosclerosis which you will look. Okay, and one more is locomotor brachialis. He has a locomotor brachialis. I'll show that. He has a locomotor brachialis. You can make out here. I'll show with a pen. See the pulsation here. Okay, that indicates atherosclerosis. Atherosclerosis. Dancing brachialis you get in aortic regurgitation. Okay, this is locomotor brachialis. In the general physical examination, other important thing which you have to look in any cardiovascular case like this, especially when you are thinking of valvular heart disease, is any signs of infective endocarditis. It's not febrile, but especially if they are febrile, you have to look for signs of infective endocarditis like anemia, osseous nodes, splinter hemorrhages, genuine lesions. Okay, those, and clubbing. Okay, these signs you have to look, signs of infective endocarditis in any valvular heart lesion. Okay, right. Coming to the examination of the cardiovascular system, first I want to tell about the JVP, and in this patient JVP is not rise. Okay, ideally you have to make him at 45-degree inclined position, and you have to look. There is no rise of JVP in this patient. Okay, right. And then let us come to the inspection, other inspection of the cardiovascular system. So what all you want to look in the inspection of the cardiovascular system examination? Okay, whether any suprasternal pulsations are visible, you have to see. There are no any suprasternal pulsations which are visible. Then you have to look the apical impulse. The apical impulse. Okay, so apical impulse, students. So students, in the inspection, there are no visible suprasternal pulsation in this patient. Then apical impulse you have to visualize. See students, here apical impulse, you can make out here. You can see the pulsation. This is in one space, but you can see also in the other space. You can make out here also. It is in two spaces, and it is lateral to midclavicular line. So this is the midclavicular line, and it is in the 6th space and 7th space. See, this is the 2nd space, 3rd space, 4th, 5th, 6th, 7th. So it is in the 6th space and 7th space. Okay, and then see, you can make out the apical impulse here, two intercostal spaces. Okay, this is the inspection of the apical impulse. So inspection, there is no suprasternal pulsations. Apical impulse, students, you can make out here in the 6th space and the 7th space, the apical impulse. Okay, 6th and 7th space. It is lateral to the midclavicular line, lateral to the midclavicular line. Okay, and it is the 6th space and 7th space. It is diffused in a two intercostal space. Okay, in the 6th and 7th space. You can make out here. He has an intercostal recession. That is why in between that you can see the pulsation here, the apical impulse, nicely visible. Okay. So what are the other inspectory findings you see in the cardiovascular system examination? Any visible epigastric pulsations you have to see. Ask the patient to hold breath in expiration. Usru horada bit aage itkoli. Usru bidi itkoli hage. It is visible, students. The epigastric pulsation is visible. Okay, then you have to look for either. Then you have to look for any visible pulsation in the left 2nd intercostal space, because if there is any visible pulsation in left 2nd intercostal space is there, that indicates dilatation of the pulmonary artery because of pulmonary hypertension. Then any visible left parasternal heave is there, you have to see. Okay, there are no visible left parasternal heave, that you have to see. And there are any visible other precordial pulsation is there, you will see. Okay. Then which are the other inspectory things? The chest deformities, pectus excavatum, pectus carinatum, kyphosis, scoliosis, which this patient is not having. Okay. So one important inspectory finding you got, the apical impulse is in two spaces, 6th and 7th, shifted downward and outward. What that indicates? LV is enlarged. This is the inspectory finding. Now let us go to the palpation. So palpation, let me palpate the apical impulse. So in palpation, three things, students. In my hand, for example, the tip is used to localize the impulse, to localize the apical impulse, the tip. Okay. The base of the fingers is used for the thrill. The base of the fingers is used for the thrill, and the base of the hand for the heave. The base of the hand for the heave. Okay. So let me look for the palpatory findings team. The apical impulse in two spaces. Students, apical impulse, okay, it is here in the two spaces. My finger is lifting up and coming down, okay. It is here in the 6th space and also in the 7th space. It is hyperdynamic. It is hyperdynamic. So what are the types of apical impulse? Tapping in mitral stenosis. It just touches your finger and comes down, that is tapping. Then you have a hyperdynamic in aortic regurgitation and mitral regurgitation, where the amplitude is increased but not the time. Whereas a heaving you get in aortic stenosis, okay, where both the amplitude and the time also will be increased more than 2/3 of the cardiac cycle. That is a heaving. Between 1/3 to 2/3 is hyperdynamic, the duration. Here it is, there are two intercostal spaces and it is hyperdynamic. And again, in hyperdynamic, it will be diffuse, two spaces, whereas if it is a heaving, only one space will be there, the apical impulse. And apical impulse is defined as the lowermost and outermost point of maximal impulse, PMI. So here there is a hyperdynamic apical impulse, indicates there is a volume overload either due to aortic regurgitation or mitral regurgitation. So that is the inference from this palpatory finding. Let me look for a thrill. Thrill with the base of the fingers you have to look. Okay, either any thrill is there. I am getting a thrill here. Okay, so I'll time with the carotids to see whether it is systolic or diastolic thrill. There is a systolic thrill. See, by and large, the thrills in the apical area is diastolic always. It is diastolic. At the base of that, the thrill is systolic. But there are some exceptions. In a severe MR, you may get a systolic thrill in the apical area, or in a severe AR, you may get diastolic thrill in the base of the heart. Thrill indicates organicity of the murmur, that is, it is organic. The severity of the murmur, that is grade 4. And then it localizes the murmur. Wherever the thrill is there, there is a pathology. So thrill. Any palpable P2 is there, I have to look. Let me look here. There is no palpable P2. Then parasternal heave. Okay, you have to look for a left parasternal heave. Parasternal heave, I'll with my ulnar border of the hand, I'll palpate. There is no parasternal heave. Parasternal heave is graded as where you can just see, inspect, okay, but not able to palpate. Grade 2, you can inspect, palpate, but you can obliterate. Grade 3 is inspect, palpate, and you cannot obliterate. This is Ames classification of parasternal heave. Okay. Next, parasternal heave indicates there are two things. One is either a RVH or left atria enlargement. Either a RVH or left atria enlargement. And you have to look for the epigastric pulsations. Okay, you have to put your thumb in the epigastric region. So epigastric pulsation you have to see. Epigastric pulsation is due to three causes, either a left lobe of liver, or a right ventricular hypertrophy, or a abdominal aorta pulsation. Even inspection, there was a visible pulsation. Even I am feeling a pulsation, probably because of the right ventricular hypertrophy, but parasternal heave is not there. Okay, right. So these are the things which you look in palpation and cardiovascular system examination. Okay, right. And now coming to the percussion. So in the palpation, what positive findings you got? You have a hyperdynamic apical impulse which indicates a regurgitation lesion and it is shifted downward and outward. Now coming to the percussion. Should you do percussion, students, here? You should not do because the patient is in atrial fibrillation. So two things is important in an exam. One is you should not do percussion in atrial fibrillation because it may dislodge the embolism. Another thing is, how do you check blood pressure in atrial fibrillation? They will ask. You have to take the average of the three readings whenever patient is in atrial fibrillation. Okay, you have to take average of the three readings. So next, going to the auscultation. Let me auscultate the areas and tell my findings. Left lateral to look for mid-diastolic murmur, students. So next you have to auscultate in the herbs area. Herbs area is left third intercostal space. Second space, third space. Leaning forward. ಉಸಿರು ತಗೊಳ್ಳಿ, ಉಸಿರು ಬಿಟ್ಟು ಹಾಗೆ ಇಟ್ಕೊಳ್ಳಿ. Breath held in expiration. So you have to look for air murmur in that area with the breath held in expiration, leaning forward. Okay. The auscultatory areas: mitral area, tricuspid, pulmonary, aortic, neo-aortic area. So what are the findings in mitral area? The S1 is soft, students. S1 is soft. There is a pansystolic murmur of grade 4/6 because I felt a thrill there. And it is blowing in character, a high pitched murmur radiating to the axilla and back. So you would always look for the axilla and back. Okay. ಕೂತ್ಕೊಳ್ಳಿ, ಹಾಕಿ ಕೂತ್ಕೊಳ್ಳಿ, ಹಾಸಿ. ಮಲ್ಕೊಳ್ಳಿ. So pansystolic murmur grade 4 in intensity, radiating to the axilla and back, blowing in character and better heard in expiration. Then there is another murmur in the same apical impulse in the wherever there is in a mitral area, a rough rumbling mid-diastolic murmur is heard of grade 3/4. The grading of the murmur, diastolic is only 4, the systolic is still 6. If it is a thrill, the grade is 4. So there is a MDM. It is a rough and rumbling murmur, low pitch with a bellowed stethoscope, better heard in left lateral position, best heard in expiration, a localized murmur. In a tricuspid area, the same pansystolic murmur is heard, okay, whatever you heard in the mitral area. In pulmonary area, S1 and S2 is heard, there is no loud P2. In aortic area, S1 and S2 is heard. Neo-aortic area, there is no murmur. This is the auscultatory findings in him. Now, let us interpret it as a two lesions now by auscultation. One, there is a PSM and another there is a MDM, which is predominant here. See, LV is shifted downward and outward. LV is enlarged. Okay, that indicates a predominant MR. That is why, though you get a loud S1 in mitral stenosis, S1 is muffled here because of the associated mitral regurgitation. That is why S1 is muffled here. Even opening snap couldn't be able to. Here, And the pre-systolic accentuation not able to make out. Why? Because he is in atrial fibrillation. Pre-systolic accentuation you get only if the patient is in sinus rhythm, or else you won't get it. And what are the auscultatory cycle you get in mitral stenosis? It occurs in a diastole between S2 and S1. After S2 you get an opening snap, then a MDI murmur, then a pre-systolic accentuation. This is a cycle what we get in MDI. The murmur here is radiating to axilla and back. That indicates the mitral regurgitation murmur is radiating to axilla and back. The anterior mitral leaflet is involved here. If posterior mitral leaflet is involved, it radiates to the base of the heart. That you see in a coronary artery disease. Whereas the anterior mitral leaflet you get in RST. And why in coronary artery disease only posterior leaflet is involved, not anterior, means because the posterior leaflet has only a single blood supply. Whereas the anterior has a dual blood supply from a LAD branch, a diagonal and a left circumflex marginal branch. Whereas the posterior mitral leaflet has a posterior descending artery from a RCA. It is the only artery. So these are the auscultatory findings. Now let us go to the respiratory system examination. Student, this is a very good case of both cardiovascular and respiratory system. Respiratory system, some of the salient points I want to discuss now here. And the same case I will bring the next discussion also, because this is a case of a respiratory case. What he is having, I will tell, and I will discuss that in detail in the next class. Today let us confine to the cardiovascular system examination and discussion. So respiratory system, let me tell the positive findings. So coming to the respiratory system examination, upper respiratory system examination, any nasal deviation or any polyp is there you have to see. Okay. Coming to the proper lower respiratory examination, inspection students, there is no drooping, you can make out there is no drooping. There is supraclavicular halones both the sides, no pectus excavatum or carinatum, no kyphosis or scoliosis. And trachea appears to be in a central position. Okay. And he has an intercostal recession, which I will show. Students, you can make out the intercostal recession here, nicely visible. Okay, in between the ribs. Okay, and his tachypnea, 24 cycles. Why intercostal recession and tachypnea? Let us discover at the end of respiratory system examination, which I will discuss in the next class also detail about this case, about the RS. There is no pectus excavatum, no carinatum, no kyphosis, no scoliosis, and there is no crowding of the ribs in inspection. Coming to the palpation, the trachea, it is central in position. I can insinuate finger both the sides equally. Okay. And the respiratory movements. I checked. Usadi ejmandre? Aramu usadi. Jora yenilla. Ni mamuli engu usadi usadi. Okay. That is for the apical part. For the anterior part, usadi. There is a reduced movement. Aside tirikoli. Usadi. It's very slightly moving, students. The hands, reduce movement. Okay. It's in happening. Okay. Then the measurements. Okay. I have taken the measurements. The AP diameter is 15. The lateral diameter is 18 centimeters. Hemithorax, right side is 37, left side is 37. Expansion, expiration 73, inspiration 73.5. Only 0.5 expansion is there. Okay, and there is a barrel shaped chest with tachypnea, intercostal recession, reduced movement bilaterally. Okay, right. Then vocal fremitus, it was normal on both the sides. Okay, now I'll discuss again this case detailed respiratory system examination next class. Vocal fremitus is normal on both the sides. There is no palpable rub, rhonchi or crepitations and palpation. No intercostal tenderness is there. Okay, right. So coming to the percussion. The percussion note, students, everywhere hyperresonant. Okay, again I'll discuss this case. Only briefly I will tell. Aramai. hyperresonant, hyperresonant, ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ. Everywhere hyperresonant. See, back also hyperresonant. Is that required? Back also hyperresonant. Then you have to look for a lever dullness and also trops area percussion. I'll do that, okay? And you will find a very interesting case in lever dullness which I'll show now. Yeah. So lever dullness I'll percuss second rib, resonant, third space resonant, fourth space resonant, fifth resonant, sixth resonant. See, eighth space almost, seventh is little dullness, eighth space here, sixth, seventh, eighth. You are getting your lever dullness in seventh and eighth space pushed down, and is a smoker for 25 years, 2 packets, 50 pack years. Drops area I will percuss second rib, third rib, fourth rib, fifth rib, sixth rib, coastal margin below, mid axillary line. Resonant. ಕೂತ್ಕೊಳ್ಳಿ, ಮಲ್ಕೊಳ್ಳಿ 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 ಸರ್, ಮಲ್ಕೊಳ್ಳಿ ಮಲ್ಕೊಳ್ಳಿ ಮಲ್ಕೊಳ್ಳಿ. So you got a hyperresonant low note everywhere, lever dullness pushed down, okay? Right, these are the percussion findings. Let me auscultate, okay? And ಇದೀಟ ಒಂದು ಒಂದು ಅಂತ ಹೇಳಿ, ಒಂದು 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 ಒಂದು. So there is a harsh bronchovesicular breath sounds heard everywhere. That's crepitation in the infra-axillary, axillary, bilaterally, infrascapular, interscapular, bilaterally. Okay. So students, he's a smoker for 25 years, and there's hyperresonant throat, reduced movement, the lever dullness pushed downwards, and bronchovesicular breath sounds heard bilaterally. So this is a case of COPD with predominantly emphysema, which I'll discuss the same case, okay, next class, okay. It's a very rare case with a fine cardiovascular as well as a respiratory system finding, which I'll discuss in the next class. These are the findings in the respiratory system examination and auscultation. Per abdomen it is normal, no organomegaly. Central nervous system it is normal, okay, there are no signs, okay, right. Malkoli. So what is the cardiovascular diagnosis in this case, students? So he had PSM, panspermia murmur in the mitral area, and a MDM in a mitral area. Okay, so this is a case of valvular heart disease, probably because of a rheumatic etiology, rheumatic heart disease, and he is in atrial fibrillation, no pulmonary hypertension, and because he has a NVHA class 3 symptoms, he is in failure. So rheumatic heart disease, mitral stenosis, predominantly mitral regurgitation, a moderate MS with atrial fibrillation, no evidence of pulmonary hypertension, no evidence of infective endocarditis, and he is in failure because of NVHA class 3. So in him, ECG and echo was done. It was showing a left atrial enlargement, and the echocardiogram showed a moderate to severe MR with moderate MS without evidence of pulmonary hypertension, and he was in atrial fibrillation. So today, let us discuss about in detail about the mitral stenosis and mitral regurgitation. Okay, students, the majority of the cases of mitral stenosis is rheumatic fever. In 25% of the cases of rheumatic fever, isolated MS will occur. In 40%, it can be a combination of MS and MR. In 38% of the patients, there will be a multivalvular involvement, with 35% with the aortic wall involvement, 6% with the tricuspid, and very rarely pulmonary valve. What is the pathology here rheumatic fever produces? There will be a leaflet thickening, commissural fusion, shortening and fusion of the cauda tendinum. The Ashoff nodes, which is the pathognomonic of rheumatic fever, is found in the myocardium. Only in 2% of the cases it will be seen in the valves. There will be a diastolic doming of the anterior mitral leaflet in mitral stenosis, producing the opening snap. But as the duration increases, the anterior leaflet will become calcified and fibrotic. The diastolic doming will disappear and opening snap will disappear. The commissural fusion will produce a fish mouth opening or a buttonhole opening of the mitral valve. If there is a predominant involvement of the cauda tendinae, the fusion and shortening without involvement of the commissures, then mitral regurgitation results rather than mitral stenosis. Repeated infection, repeated streptococcal infection, ongoing autoimmune destruction, or a superadded calcification. Which are these three things will produce MS? Debate is going on since 100 years. Any of these three things could be the cause of the rheumatic heart disease and mitral stenosis. So what is the pathophysiology? The first attack of the pulmonary edema can be produced by fever, tachycardia, arrhythmias, infections, pregnancy, thyrotoxicosis. And whenever there is an increased tachycardia, there is an increased blood flow, so left atrium will get congested. And whenever there is a tachycardia, the diastolic filling time will reduce. So tachycardia will reduce the diastole more compared to the systole. So the filling of the LV will reduce. So left atrium will get congested, and that produces pulmonary edema. Mitral valve has been classified based on the valve size. The normal valve size is 4 to 6 centimeters square. A mild mitral stenosis is less than 2 centimeters square. Moderate less than 1.5, less than 1 centimeter is very severe. In a very severe MS, you require the gradient between LA and LV will be 20 mm of Hg. So you require 25 mm of Hg, more than that, to pass the blood from LA to LV. Atrial contraction will contribute to 30% of the flow from atria to ventricle. So whenever there is a atrial fibrillation, there will be a 20% reduction of the cardiac output. Coming to the hemodynamic consequences. Whenever there is a mitral stenosis, there will be back pressure, the pulmonary vascular resistance will increase, thereby the pulmonary artery pressure will increase, which reduces the cardiac output. The pulmonary hypertension can occur because of a passive backward flow, backward pressure from the LA, or reactive pulmonary hypertension, or there can be organic obliterative changes in the pulmonary vasculature. Any of these three things can produce pulmonary hypertension. So whenever this pulmonary congestion, pulmonary hypertension will occur, the bronchial vein and pulmonary vein will get dilated, which can produce hemoptysis. The lung compliance will get reduced, vital capacity will reduce. and there is a redistribution of blood flow from the lower part of the lung to the upper part of the lung. One thing, students, in mitral stenosis, LV is normal. Isolated MS, LV is normal. Left ventricular end diastolic pressure is also normal. Its systolic function is normal. But here what happened? LV shifted downward and outward. So this is not isolated MS in our case. That's a combination because LV should be normal. Its apical impulse should be normal space in isolated MS. So when left ventricular end diastolic pressure will increase in isolated MS, associated MR like this are AR or hypertension, coronary artery disease, myocardial infarction, then only the left ventricular end diastolic pressure will increase. Okay, students, right. So there are two extremes of mitral stenosis. In one set of patients, there will be decreased cardiac output where they have fatigue. In one set of patients, the pulmonary capillary wedge pressure will increase, producing a congestion. In a critical MS, there will be a reduced cardiac output at rest, and with exercise, there will be a pulmonary congestion also. In a critical MS, which is less than 1 centimeter square. Then come to the left atrial changes. Because there is a mitral stenosis, the LA will get enlarged, so there will be LA enlargement, left atrial fibrosis, and there will be a disarray of the atrial muscle fibers. So left atrial dilatation, left atrial pressure, and atrial fibrillation is not related, it can occur independently of the severity of MS or LA enlargement or LA pressure. And once atrial fibrillation starts, AF begets AF. What is the meaning? AF will produce LA dilatation, the thinning of the LA muscles, and increase the refractoriness of the conduction. So AF begets AF. So that is the left atrial changes. Now come to the clinical presentations. So they'll have dyspnea, orthopnea. I explained the mechanism why they'll have orthopnea and dyspnea. Hemoptysis. What are the causes of hemoptysis in MS? Is a standard question in exams. Why they'll have hemoptysis in MS? The mechanisms are, one, as I told, there can be an opening up of the bronchial veins and pulmonary vein blood circulation where bronchial vein can rupture. There can be a speaking hemoptysis of the sputum in a PND. Or in pulmonary edema, pink frothy sputum can occur because of alveolar capillary rupture. Mitral bronchitis can produce a hemoptysis, a pneumonia, anticoagulation which you treat for atrial fibrillation. All these things can produce a hemoptysis. Chest pain. Chest pain can occur in mitral stenosis because of pulmonary hypertension and RVH. That is one mechanism. Embolism can be thrown to coronary arteries. That is the second mechanism. And the third, they can have chest pain where there is no explanation. See, our patient has chest pain. He has chest pain, our patient. Then left recurrent laryngeal nerve palsy. It can occur because of LA enlargement, pulmonary artery enlargement, that is known as the Otten syndrome, or tracheobronchial lymph node enlargement. Any of these things can produce a left recurrent laryngeal nerve palsy. Then you will have tachycardia and embolization because of atrial fibrillation. That is another clinical manifestation. Then repeated pulmonary hemoptysis can produce a pulmonary hemosiderosis, which I have an X-ray which I will show that. Then if they go for a pulmonary hypertension right heart failure, they will have a rise JVP, tender hepatomegaly, ascites and pedal edema, a systemic venous congestion. Coming to the signs, what are the signs you look in this case? In the phase, students, you have to look for a mitral phasing because of the vasoconstriction. In a chronic severe MS, they will have a mitral phases which you have to look. Chronic severe MS, they will have a mitral phases. In isolated MS, pulse will be, volume will be less, but in our case, it is high volume because it is a combination of MS and MR. That is why pulse volume is high. BP blood pressure will be on the lower side. JVP, If there is a pulmonary hypertension, A wave will be prominent. If it is atrial fibrillation, A wave will be absent. So, if atrial fibrillation, X descent also will be absent, CV will become more prominent. CV will become more prominent. Coming to the cardiac examination, signs. Palpation, as I told, the apical impulse will be tapping in nature, and if thrill is there, that's grade 4. Palpable P2 indicates a pulmonary hypertension, and a paroxysmal heave indicates a RVH. Paroxysmal heave indicates a RVH. Then auscultation. Auscultation, you will get a loud S1 if the valves are pliable. Loud S1 you can get in mitral stenosis, tricuspid stenosis, and tachycardia. You may get a loud P2 because of pulmonary hypertension, RV S3 and S4 if there is a right heart failure, and a TR murmur also right side. And if pulmonary hypertension, you may get a early diastolic murmur, a Gram-Stein murmur. Then specific mention about two things. One is opening snap and MDM. Opening snap, it is a high pitched sound heard in mitral area with a diaphragm. It is due to the sudden tensing of the mitral leaflets. Opening snap, sudden tensing of the mitral leaflets. If opening snap is heard, the valves are movable, pliable. If it is calcified, opening snap will be absent. Opening snap and S1 are corollaries. If S1 is not heard, opening snap is not heard. And two opening snap gap. S2 opening snap gap is very important because to assess the severity of the murmur. Students in mitral stenosis, the pitch of the murmur doesn't indicate the severity, whereas the duration of the murmur and the two opening snap indicate the severity. If the two opening snap is short, the severity of the MS is severe. The normal two opening snap is 40 milliseconds to 120 milliseconds. 40 milliseconds to 120 milliseconds. Now coming to the MDM murmur. As I told before, the auscultatory cycle is S2, opening snap, MDM, presystolic accentuation. MDM is a rough and rumbling murmur, better heard with a low pitch murmur. With the bell of the stethoscope, you have to auscultate. Bell, you will auscultate MDM, S3 and S4. In the left lateral position, breath held in expiration, and it is a localized murmur. And if the patient is in sinus rhythm, there will be a presystolic accentuation. If they are in atrial fibrillation, presystolic accentuation won't be there. The differential diagnosis for the MDM are acute rheumatic fever, mitral valvulitis, which is a Kerikmus murmur, Austin Flint in a aortic regurgitation, ASD, VSD with a flow murmur, MDM murmur, or mitral annular calcification. Even Brownwell gives HOCM as a DD for MDM in mitral area. So these are the clinical features what you will get. Okay. Come to the investigation of a mitral stenosis students. ECG. ECG will show left atrial enlargement P mitral. P mitral in lead 2, where the duration of the P wave is 0.12 seconds, more than 0.12 seconds, which I will show the ECG after the discussion in the PPT. RVH can be there in mitral stenosis. The RVH will correlate with the pulmonary artery pressure. 2D echocardiogram definitely establish a diagnosis in mitral stenosis. The mitral valve area can be assessed by three things. One is pressure of time, planimetry, and PISA. What is PISA? PISA is proximal isovelocity surface area. This is a DM level, but if you know, it's well and good. Okay, pressure of time, planimetry, and PISA method. These are the methods by which mitral valve area is calculated in 2D echo. One thing in 2D echo which you have to do is Wilkins score. Wilkins score is assessed by four things: the valve thickening, the valve mobility, calcification, subvalvular fusion. A score is given from 0 to 4 for each. Valve thickening, valve mobility, subvalvular fusion and calcification. If score more than 8, then valves are deformed. You can't do percutaneous balloon mitral valvotomy. You have to do a valve replacement. Chest X-ray. There are some classic X-ray features in mitral stenosis. There can be a widening of the carina, straightening of the left heart border because of LA enlargement and LA appendage enlargement. Curly A line and B line. Curly B line from the costophrenic angle at the base, horizontal lines you get. Curly B lines, if the pulmonary capillary wedge pressure is 20 mm of Hg, you get in 30%. If more than 20 mm of Hg pulmonary capillary wedge pressure, you get 70%. Curly A line, which will go towards the hilum, indicates pulmonary capillary wedge pressure more than 30 mm of Hg. Pulmonary hemosiderosis, because of repeated hemoptysis, which I have on X-ray, I will show the pulmonary hemosiderosis. And mitral valve calcification as well as annular calcification also you may see. Annular calcification is better in mitral regurgitation. Here mitral valve calcification you may see in a chest X-ray. Then you can do CT, MRI and catheterization. While doing catheterization, you can measure the mitral area by Gorling's formula. So these are the investigations which you will do in mitral stenosis. The valve area will reduce approximately by 0.09 centimeters square per year. But in some patients, there will be a rapid narrowing, that is 0.1 centimeter square per year. The rate of narrowing of the mitral valve area in MS. Then the clinical outcome, if the patient is in NYHA 3, 5-year survival rate is 60%, in NYHA stage 4, 5-year survival rate is only 15%. Coming to the complications of mitral stenosis. So you will have atrial fibrillation and embolization. In 20% of the patients with embolization, there is sinus rhythm. They won't have atrial fibrillation. The explanation may be one is intermittent AF or infective endocarditis. In 40% of the patients with sinus rhythm have a spontaneous echo contrast up of smoke in LA. The explanation for the embolism, those patients are in sinus rhythm, are probably endothelial dysfunction, platelet aggregation, inflammation going on. These are some of the explanation for patients who have embolization in spite of sinus rhythm. Embolism in atrial fibrillation can be thrown commonly 50% to the cerebrum. It can thrown to renal artery producing hypertension, and peripheral arteries it can throw the embolism, atrial fibrillation. Once atrial fibrillation develops, the prognosis is very bad in MS compared to MR. MR atrial fibrillation, it worsens but not like MS. Because AF, the blood will flood in the LA and also time for the filling from LA to LV reduces. So there will be a congestion because of atrial fibrillation. Next is infective endocarditis. The risk is very less in MS, only 1% of the patient with infective endocarditis have MS. The lesser the MS, the risk is more. In the severe MS, when it becomes calcified, the risk is less. A less severe MS has a more chance of getting infected endocarditis, but still overall it is very less developing infective endocarditis in MS. So these are the complications of mitral stenosis. Now coming to the management, the medical line of management of mitral stenosis. You have to give penicillin prophylaxis, treat the anemia, treat the infection. If there is hemoptysis, you have to sedate, put them in upright position, give aggressive diuretic management. If patient is in atrial fibrillation, you will give beta blockers, calcium channel blockers. Then for acute management, you'll heparinize and you'll give vitamin K oral anticoagulant, warfarin, but not the novel oral anticoagulant. Novel oral anticoagulants are not recommended in atrial fibrillation like dabigatran, edaxaban, apaxaban, or rivaroxaban. Patient if LV dysfunction is there or sedentary, digoxin can be given in atrial fibrillation. So if heart rate could not be controlled with beta blockers and calcium channel blockers, you can give digoxin and amiodarone in atrial fibrillation. And if patient is undergoing a mitral valve replacement, atrial fibrillation with the patient has at the same setting you can do a MACE procedure. Then what are the indications of vitamin K anticoagulant in a case of MS? MS with AF, you have to anticoagulate. Evidence of embolization, you have to anticoagulate. Spontaneous echo contrast on 2D echo, you have to anticoagulate. Documented LA thrombus on echocardiogram, you have to anticoagulate. And LA diameter more than 55 mm, you have to anticoagulate. And INR you maintain between 2 to 3. So this is the medical line of management of mitral stenosis. So next is, how do you treat MS with a valvotomy? The indications for valvotomy. So there is a percutaneous balloon mitral valvotomy, PBMV, percutaneous balloon mitral valvotomy. Then you have open commissural valvotomy or a closed commissural valvotomy. Then valve replacement. So these 4 things. Nowadays, most of the things, if valves are pliable, they are doing percutaneous balloon mitral valvotomy, PBMV. And if valves are deformed, they do valve replacement. So how do you proceed? What are the guidelines for intervention in a mitral stenosis? So a very severe mitral stenosis defined by the mitral valve area less than 1 centimeter square or the pressure of time less than 220 milliseconds. A very severe MS. A very severe MS can be symptomatic or asymptomatic. If a very severe MS is symptomatic and if the valve morphology is good, that is, valve morphology is good, there is no LA thrombus, no associated MR, then you go ahead with the percutaneous balloon mitral valve. If the valve morphology is bad, then if the patient is not in a NYHA4 or if he is surgically fit, then you will do mitral valve replacement. But if the patient is in NYHA4 or surgically not fit, in him also, then you do only percutaneous balloon mitral valve. This is in a symptomatic patient. So let us go. So let us discuss the indications for the interventions in mitral stenosis. A very severe MS is defined by mitral valve area less than 1 centimeter square and pressure of time less than 220 milliseconds. A very severe MS can be symptomatic or asymptomatic. A very severe MS if is symptomatic, if the valves are pliable and favorable morphology, then do percutaneous balloon mitral valvotomy. If a very severe MS patient has unfavorable morphology, LA clot or associated MR, then you assess his condition, whether he is in NYHA4 or not, surgically fit or not. If he is not in NYHA4 or surgically fit, do mitral valve replacement. If he is surgically unfit, NYHA4, in him also you do percutaneous balloon mitral valve. This is in symptomatic patients. In asymptomatic patients with a mitral stenosis, you assess the valves. If the valves are pliable, not deformed, then you do a percutaneous balloon mitral valve. In a very severe MS asymptomatic patients, if the valves are deformed, malformed, if he is surgically fit, then you do a valve replacement. In a very severe MS, asymptomatic, if the valves are deformed, not fit for a surgery, for a valve replacement, then you just periodically follow it. Next comes severe MS, where the valve area is less than 1.5 centimeter square and pressure of time is more than 150 milliseconds but less than 220 milliseconds. So, severe MS can be symptomatic or asymptomatic. So, if symptomatic, follow the same approach. You assess the valve morphology, no LA clot, no MR, do percutaneous balloon mitral valvotomy. If valves are deformed, if there is associated MR or LA clot, and if surgically fit, do a valve replacement. And if surgically not fit, if valves are deformed, in them also you do percutaneous balloon mitral valvotomy in symptomatic patients of severe MS. In asymptomatic patients with severe MS, if there is atrial fibrillation, if the valves are pliable, no LA clot and no MR, you go ahead with PBMV, percutaneous balloon mitral valvotomy. If valves are not suitable, just follow them. Just periodically follow them. This is in severe MS, asymptomatic. Next, you have a progressive MS where the valve area is less than 2 centimeter square and the pressure of time is less than 150 milliseconds. In them, you have to assess with the exertion the pulmonary capillary wedge pressure. So, with the exertion, if the pulmonary capillary wedge pressure is more than 15 mm of Hg, and if the valves are pliable, do a PBMV. And if valves are not pliable, no LA, if there is LA clot, if there is associated MR, you just follow the patient, just monitor the patient. This is the guidelines for the management of mitral stenosis. Okay, students, when you do a PBME, the pressure will reduce from 18 to 6. The gradient will reduce from 18 to 6, from LA to LV gradient. The valve area will increase from 1 to 2 centimeters square. Pulmonary artery pressure will reduce, pulmonary vascular resistance will reduce. Depending upon the gradient between LA and LV, MS also is classified into mild, moderate, severe. If gradient is 5 mild, 5 to 15 moderate, more than 15 severe. A gradient of 3 mm of H is enough to produce a murmur between LA and LV. Patient can develop symptoms after percutaneous balloon mitral valvotomy because of 4 reasons. Could be an inadequate first procedure, or a development of AR or MR later, or due to the iatrogenic MR produced by the intervention, or associated coronary artery disease. All this can produce the symptoms after percutaneous balloon mitral valvotomy. So, this is the other 3 surgeries, as I told: open mitral valvotomy, closed mitral valvotomy, and valve replacements. They do transcatheter aortic valve replacement, TAVI for aorta, but for a mitral valve, still it is in a very nascent stage. They are not able to do that procedure. So, this is about mitral stenosis. So, students, in a progressive MS, where the mitral valve area is less than 2 centimeters and pressure of time is less than 150 milliseconds, the pulmonary capillary wedge pressure is more than 25 mm of Hg, and if the valves are pliable, then you have to do a PBME. If valves are not pliable, then just monitor the patient. Okay, right. So, let us go to the discussion of mitral regurgitation. So, first is the causes of mitral regurgitation, acute and chronic. What are the cause of acute mitral regurgitation? See, student, the mitral valve apparatus has an annulus, then you have a cauda tendina, a papillary muscle. Okay. So, problem and a leaflet and a mitral valve leaflet. A leaflet, annulus, cauda tendina, papillary muscle, which the PPT I will show the anatomy of the mitral valve, which they will ask in the exam. you should be able to write the mitral valve whenever you get a valvular heart disease patient. You should know how to write the mitral valve. So let us go one by one. What are the cause of in acute MR? Annulus causes. Myocardial infarction, infective endocarditis, trauma. Then suture leakage, because of which it produces paravalvular leakage. Because of suture disruption, paravalvular leakage. So infective endocarditis and trauma. Come to the leaflets. Leaflets, infective endocarditis, trauma, rheumatic heart disease. Then you have atrial myxoma, SLE can produce a leaflet. Infective endocarditis by the vegetations which will hinder the closure of the valves by which it can produce. Blunt traumatis by perforation of the valve, it can produce a MR. Then you have cardiac tendine. Then in the leaflets, one more etiology is myxomatous degeneration of the valves producing MEP or because of Marfan syndrome. Cardiac tendine, the causes are trauma, infective endocarditis, acute rheumatic fever, then myxomatous degeneration of the valves like MEP, Marfan syndrome, Ehlers-Danlos syndrome can produce because of the cardiac tendine. Then papillary muscle, ischemia and myocardial infarction, global LV dysfunction, trauma, infiltration of the papillary muscle because of amyloidosis and sarcoidosis. Then prosthetic valve problems. There could be a degeneration of the porcine valve or there could be a perforation of the porcine valve. Or there can be obstruction of the ball and cage can produce a prosthetic valve, acute mitral regurgitation, and a strut fracture also. Come to the chronic MR, inflammation, rheumatic heart disease, SLE, rheumatoid arthritis, infection, infective endocarditis. So inflammation, infection, then structural deformity. The structural deformity could be in the annulus, producing a LV dilatation and LV aneurysms can produce a mitral regurgitation, or a mitral cardiac tendine can be involved again because of myocardial infarction or myxomatous degeneration. Annulus because of the annular calcification, and papillary muscle also can be involved because of myocardial infarction. Then HOCM can produce mitral regurgitation because of SAM motion, systolic anterior motion of the mitral valve to the septum, which will direct posteriorly to the axilla and back. Then congenital causes, endocardial cushion defect, cleft mitral leaflet, which you get in ostium primum ASD. So there are so many, and then you get in transposition of great vessels, Alcapa, anomalous left coronary artery from pulmonary artery, Alcapa, transposition of great vessels, endomyocardial fibroelastosis. These are the congenital causes. As far as mitral stenosis, rheumatic fever is the most cause for mitral stenosis. The other cause of mitral stenosis are rheumatoid arthritis, SLE, Whipple's disease, Hunter's, Ehlers, methysargide, carcinoid syndrome. Schoen complex for MS. Schoen complex is a supramitral membrane and a subaortic membrane along with a parachute mitral. Parachute mitral valve is single papillary muscle and coarctation of the aorta. It is a congenital MS, Schoen complex. So those are the rare cause of MS. Rheumatic fever is the only etiology, but for MR, these are the causes. So acute, chronic, mitral valve apparatus you remember, annulus, leaflet, carda, papillary muscle. One by one you can remember and tell what are the causes of acute and chronic mitral regurgitation. mainly divided into primary and secondary. Primary is the inherent diseases of the mitral valve leaflet, whereas secondary is because of the annular dilatation like in a cardiomyopathies. It is a functional usually, secondary, whereas the primary is organic and involves the leaflet. Then you have a Carpenter classification of mitral regurgitation. This is given in Brownwell Carpenter classification, where there will be a normal valve motion but still MR will occur because of ischemic cardiomyopathy or dilated cardiomyopathy. Then increased leaflet valve motion producing a mitral regurgitation. Example in MEP and Marfan syndrome. Then you have a restricted valve motion. In restricted valve motion, 3A and 3B it is classified. 3A is defect in the opening. You get in endomyocardial fibrosis, carcinoid syndrome. Restricted valve motion with a defective closure. Again, the cause is ischemic cardiomyopathy or a dilated cardiomyopathy. This is a Carpenter classification of mitral regurgitation. Given in Brownwell with the diagrams, you can go through it again, no problem. Then you should know mitral annular calcification, which can produce mitral regurgitation. There are some risk factors for mitral annular calcification like diabetes, hypertension, hyperlipidemia, Marfan's, Hurler syndrome, CKD, mitral annular calcification. So then, what are the symptoms of mitral regurgitation? In a chronic MR, there is a decreased cardiac output which will produce the symptoms like tiredness. The main difference between acute MR and chronic MR is LA compliance, left atrial compliance. Students, in a chronic MR, LA has time to enlarge, to increase the compliance, it can dilate. Whereas in acute MR, no time. So LA compliance is either normal or reduced in acute MR. LA size will be normal, compliance will be normal or reduced. That is why in acute MR, because the sudden blood gush into the LA pressure increases suddenly, that will increase the pulmonary capillary wedge pressure and they'll go for a right heart failure with pulmonary hypertension. That is the main difference between the symptoms between chronic MR and acute MR. MR, because of mitral valve prolapse, usually they are asymptomatic, but some patients will have a palpitation, pre-syncopal, syncopal symptoms, autonomic dysfunction, neuropsychiatric disturbances. MVP may have an atypical chest pain, which may mimic like an anginal pain but of a prolonged duration, and stabbing, pricking pain, a short duration, which comes in the apex of the heart. Even MEP patients may have arrhythmias. They can have arrhythmias. These are the symptoms, okay, of the mitral regurgitation. Okay, come to the physical examination of mitral regurgitation. What all you get? You get a pansystolic murmur in a mitral area, blowing high intensity sound, which radiate to the axilla and back if anterior mitral leaflet is involved, like in rheumatic heart disease, or if posterior mitral leaflet is involved to the base of the heart, like in ISD. As I told, why ISD posterior leaflet is involved? Because it supplies by only one coronary artery. Anterior has a dual supply, so that's why it usually doesn't involve the anterior mitral leaflet. S1 will be soft. The other cause of PSM are tricuspid regurgitation and ventricular septal defect. And if it is an acute MR, you will get a loud P2, a Gram-Stein murmur, RVS3, RVS4 and tricuspid regurgitation, a right heart failure if it is an acute MR. Then students, if it is a MEP, you will get a mid-systolic click and a late systolic murmur. Mid-systolic click, late systolic murmur. All the cause of acute MR produces early systolic murmur. And we should know about a dynamic auscultation in MR, because to distinguish MR from MR with MEP. Standing reduces the murmur of MR, whereas increases the murmur of MEP. Valsalva maneuver will reduce the murmur of MR, increases the murmur of MEP. Isometric exercise will increase the murmur of MR, reduces the murmur of MEP or HOC, or even AS, aortic stenotic murmur. So, a dynamic auscultation you should know MR to distinguish from MEP. Students, there is one entity known as silent MR given in Brownwell. In some of the cases of MR, you may not get the murmur. What are the cause of silent MR which is given in Brownfield? Obesity, emphysema, IHD, LV dilatation and annular dilatation, then acute MRs and prosthetic valve. In these MR will be silent MR. So these are the auscultatory signs you get in mitral regurgitation. And the murmur in MEP is also called as honking in current. Okay, now next come to the diagnosis and evaluation of mitral regurgitation. ECG, again like in MS, will show left atrial enlargement, will be enlarged ECG. RV can be enlarged in 1/3 of the cases, right atrial enlargement can be seen in 1/3 of the cases. 2D echocardiogram will establish the mitral regurgitation. Depending upon 2D echo Doppler only, it is classified into a severe MR and a progressive MR. Severe MR is defined by vena contracta of more than 0.7. What do you understand by vena contracta? Vena contracta is the jet where the jet diameter is very smallest and velocity is highest. That is vena contracta. Vena contracta more than 0.7 centimeter, or the regurgitant volume more than 60 ml, or the regurgitant fraction more than 50%, or the effective regurgitant orifice more than 0.4 centimeter. If these things are there, it is severe MR. Severe MR symptomatic is stage D. Severe MR asymptomatic is stage C. And progressive MR is stage B. And only at risk for developing MR but still has not developed is stage A. This is the staging of mitral regurgitation. Stage A, B, C, D. I will repeat. At risk to develop MR but still not developing is stage A. Progressive MR is stage B. Severe MR asymptomatic is stage C. Severe MR symptomatic is stage D. So in a progressive MR, the vena contracta is less than 0.7 centimeter square. The regurgitant volume is less than 60 ml. The regurgitant fraction is less than 50%. Regurgitant orifice is less than 0.4 centimeter square. So 2D echo, you will do that. Then you can do CT, MRI. Then chest X-ray very important in mitral regurgitation. Student, aneurysmal dilatation of LA occurs in MR compared to MS. MS also LA occurs, but a huge dilatation of LA occurs in MR compared to MS. So huge cardiomegaly with little parenchymal lung changes goes in favor of MR, whereas a moderate cardiomegaly with a more changes in lung parenchyma goes in favor of mitral stenosis. And chest X-ray, you will see a mitral annular calcification, especially the posterior 1/3, appear as a C-shaped calcification in chest X-ray. So these are the investigations which you will do, okay, in mitral regurgitation. The disease course, students, those who are asymptomatic severe MR, within 5 years they will develop the LV dysfunction and symptoms. Around 40 to 50% of the patients will develop that. That is the disease course in mitral regurgitation. Coming to the medical line of management. The afterload reducing agents are very effective in acute MR, acute chronic MR. The afterload reducing agents are not helpful in chronic primary MR, but they are helpful in secondary MR and acute MR. In acute MR and secondary MR. If there is a LV dysfunction, then you can give a beta blocker and a angiotensin converting enzyme inhibitor. You can give a angiotensin converting enzyme inhibitor and a beta blocker. If there is atrial fibrillation, you have to anticoagulate. And students, one thing you remember, both in MS and MR, latest guideline says infective endocarditis prophylaxis is not recommended. Routine infective endocarditis prophylaxis is not recommended. The latest guidelines for both MS and MR. Okay, right. So next is the surgical treatment. So this is important surgically. What are the indication guidelines for the treatment, the intervention in mitral regurgitation? So students, in a multi-regurgitation, severe MR, as I told, by 2D echocardiogram, vena contracta more than 0.7 centimeters square, regurgitant volume more than 60 ml, regurgitant fraction more than 50%, and effective regurgitant orifice more than 0.4 centimeter. This is a severe MR. If they are symptomatic, that is stage D. If they are symptomatic, that is stage D. What do you do? In them, you have to measure the LVEF, whether it is more than 30% or less than 30%. If the LVEF is more than 30%, you do a valve replacement. Less than 30%, then also you do a valve replacement, but that is a stage 2B indication. If LVEF is more than 30%, it is a stage 1 indication. So this is stage D. That is a severe MR, which is symptomatic. Now, a severe MR measured by all those echocardiographic criteria which I told you, if it is asymptomatic, what do you do? If it is asymptomatic, what do you do? If it is asymptomatic, then a 3 set. One is LVEF between 30 to 60%. So, severe MR asymptomatic has been divided into three groups. The first group is ejection fraction between 30 to 60%. End systolic diameter more than 40 mm. So, in this group, you directly go ahead with the valve replacement. The next stage is ejection fraction more than 60%, end systolic diameter less than 40 mm. In them, if there is a progressive reduction in the ejection fraction and if the surgical capacity of that institution is 95% success, less than 1% mortality, then go ahead with valve replacement, or else just monitor the patient. Then the next group is those who are having a AF or a pulmonary capillary wedge pressure more than 50 mm of Hg. Again, in this group, you assess the hospital capacity, whether 95% success rate and less than 1% mortality. If it is there, go ahead with the valve replacement, or else just observe. And in a progressive MS, which I told of those echocardiographic criteria, you just observe. Which is a stage B. You just observe. And what all these things I told is for a chronic severe, is for a chronic primary MR. Whereas for a chronic secondary MR, secondary causes like a valve dilatation, annular dilatation because of cardiomyopathy, chronic secondary MR, the stage is same. It is also stage same like chronic primary MR. That is a severe MR based on those echocardiographic criteria, vena contracta, regurgitation fraction, orifice. And if it's symptomatic, it is stage D. If it is asymptomatic, stage C. And a progressive MR, it is stage B. And at risk is stage A. So, in a secondary chronic MR, what you do is, if it is a severe MR, go ahead with a valve replacement. But you have to treat the angina, you have to treat the heart failure, and you have to do CRT therapy. What is CRT therapy? Cardiac resynchronization therapy with the pacemakers. So you have to do that and then go into the valve replacement. Whereas a severe MR, stage C, which is asymptomatic, as well as a progressive MR, which is a stage B, you just follow the patient. You won't do valve replacement. This is the surgical management indications of valve replacement in mitral regurgitation. Students, the flow diagram is in brown world. You can read 1 or 2 times. This indication may be helpful for postgraduate students. I don't want to burden this much information to undergraduate students. PG students, if they know well and good, examiner will get impressed. So next is the indication of surgery. Okay, right. So then chronic secondary MR, like I told, the annular dilatation because of the cardiomyopathies, usually is a functional MR. They are associated S3 and MDM will be there, flow MDM. The murmur will be silent, difficult to appreciate the murmur. The treatment is annuloplasty and CRT therapy, cardiac resynchronization therapy, diagnosed by echo, MRI and ECG. Next is acute MR, very important. The main 4 causes of acute MR are prostatic valve dysfunction, infective endocarditis, coronary artery disease producing papillary muscle dysfunction, and spontaneous rupture. I repeat, spontaneous rupture, ISD producing a papillary muscle dysfunction, infective endocarditis, prosthetic valve dysfunction. In acute MR, the murmur will be early systolic. They will have a pulmonary congestion, pulmonary vascular resistance will increase, and as I told, pulmonary compliance is normal or less. So suddenly the pressure increases in the atria, so they will develop pulmonary hypertension, RV failure, RV S3, S4, TR murmur, early diastolic murmur of a pulmonary hypertension. So all these things can develop in acute MR. Acute MR, LV size will be normal, no time for LV to dilate. X-ray will show no cardiomegaly. How do you manage the acute MR? You have to give us afterload reducing agent nitroprusside is a life-saving. Then if still hypotension is there with the nitroprusside, you have to give dobutamine and IABP to treat the shock. If papillary muscle dysfunction is there producing a heart failure, you have to treat with these medications for 4 to 6 weeks to stabilize and then go for a surgery. But if the patient develops multi-organ dysfunction, better not to prolong the medical line of management. And in acute MR, if the etiology is due to infective endocarditis or a prosthetic valve dysfunction or patient is in heart failure, the mortality of surgery is more in acute MR. Students, not only the mitral valve replacement, you can just repair the mitral valve in some other conditions in MR. It's called mitral valve repair. In whom you can do mitral valve repair? A young patients, children and adolescents with a MEP and a pliable valve or a papillary muscle dysfunction producing a MR or a caudal rupture, a leaflet rupture by infective endocarditis, you can repair it, a mitral valve. So this is about the mitral regurgitation discussion. Now 2 points I want to tell students in this discussion. Actually, I want to tell about acute rheumatic fever because it becomes lengthy. I have kept that while I discuss with the AS with AR. In detail, I will discuss the acute rheumatic fever. But today, I thought I will discuss the 2 parts. One is the causes of multivalvular lesions. What are the diseases? It will be asked in the exams. They will ask this question. What are the causes of multivalvular involvement? Diseases producing multivalvular involvement. And another is about the prosthetic valves. Which are diseases which produce multivalvular involvement? Acquired and congenital you can divide. Acquired and congenital. Acquired rheumatic heart disease is the commonest, what we all know. Degenerative, old people calcification, degenerative diseases can produce multivalvular involvement. Mitral valve, aortic valve like that. Carcinoid syndrome can produce a multivalvular involvement. SLE can produce a multivalvular involvement. Infective endocarditis can produce more than 2 valves, infective endocarditis. Iatrogenic because of radiation, methotrexate therapy. Dilated cardiomyopathy, it can produce TR and MR. And congenital shown complex, as I already discussed, can produce MS, AS, coarctation of aorta, Ehlers-Danlos syndrome, Marfan syndrome, congenital. Then congenital 13, 18, 21 trisomy. Everything given in Brown in one table, students. PG students I am referring specifically. You can go through that table, given the multivalvular involvement, what are the causes. Then about a brief points about prosthetic valves. Which valves to replace in whom? In a mitral valve disease, valve replacement is indicated if MR is 2 or plus Wilkins score is more than 8 or a previous valvotomy, you have to put a valve. So you have a mechanical valve and a bioprosthetic valve. Mechanical valve is indicated in a younger patient less than 50 years. No contraindications to the anticoagulation, and in their AF, it is still good. You can go ahead with the mechanical valve because anyhow they need anticoagulation. Bioprosthetic valves more than 70 years, contraindications to anticoagulation, and pregnant females. In between 50 to 70, you can take a decision, either of that can be put. Which are the mechanical valves? Ball and cage, that is Stahl Edwards. Tilting disc, St. Jude or George Shelley. Tilting disc. Tilting disc is preferred compared to the ball and cage because it is small size, it can be fit into small left ventricular cavity, hemolysis is less, and strut fracture is less. Hemolysis is less, strut fracture is less. It fits finely into the LV cavity. I have shown the diagram on the PPT, the valve students. After the discussion, I will show that. Then, what are the bioprosthetic valves? You can have a porcine valve, a pericardial valve, or a homograft. And the pulmonary valve can be put into the aortic valve on the same patient. These are the bioprosthetic valves. So, this is the discussion about the mitral stenosis and mitral regurgitation. And I will tell about rheumatic fever students definitely when I discuss AS and AR. So, you can read Braunwald and make a notes. And even I have given an audio clip. You can listen to the audio clip of MS and MR. And in the PPT now I will show the ECGs and X-rays, which I will discuss. So this should be a complete discussion. If you get MSMR, should be able to answer all the questions. Thank you. One point, students, this patient is a male patient. He had abdominal thoracic. I think by slip of tongue I told thoraco-abdominal respiration while telling the examination. Just I want to correct that point. Thank you, students.
Hello students, we discussed detail about a case of mitral stenosis and mitral regurgitation. So I want to discuss a few important points about the X-ray feature, the ECG features of mitral stenosis and mitral regurgitation, and also the indication of surgery in mitral stenosis and mitral regurgitation, and a few points about the artificial valve. Okay students, first I'll discuss briefly about the anatomy of the mitral valve. Okay students, right. So anatomy of the mitral valve I'll discuss. So here the mitral, the Latin word means it is the hat of a bishop. Okay, it looks like that. It looks like the hat of a bishop. So here you can see the anterior leaflet. This is the anterior leaflet. Okay, students, right. And here you can see the posterior leaflet. This is the posterior leaflet. This is the anterior leaflet. Okay, these are the leaflets. There are two leaflets in a mitral valve. Tricuspid valve, it has 3 leaflets. Then these leaflets are held by cardiac tendon. Here you can see the cardiac tendon, and here you can see the papillary muscles which are attached to the ventricular muscles. So you have 2 papillary muscles and the cardiac tendon is attached to that, to the mitral leaflets. This the picture gives a typical of a bishop's hat. That's why in the Latin word it is called as the mitral. Okay, students, right. So next is the ECG of the mitral stenosis. As you know, in mitral stenosis, the left atria will be enlarged. The left atrial enlargement is known as the P mitral in ECG. So here you can see in lead 2, you will see this is a right atria, this is a left atrial complex. So giving a wide and P wave. If it is more than 3 small squares, that is 120 milliseconds. 1 small square is 40 milliseconds, 0.04 second. So 3 small squares is 120 milliseconds. If it is enlarged, it's called as a P mitral. And in a lead V1, you can see a biphasic P wave, one positive and one negative. Okay, the biphasic P wave. Okay, right. That is the main ECG picture in mitral stenosis. So here you can see the ECG picture in lead 2. This is a right atrial, this is a left atrial. A P mitral, typically showing biatrial and the left atrial enlargement. These are left atrial enlargement. Okay, students, right. And then the chest X-ray, the important, they'll ask in the exam what are the X-ray features in mitral stenosis. So you should know about the mitral stenosis. The double atrial shadow you can make out here. This is the right atria. This is a left atrial enlargement. Atria in atria. Double atrial shadow is one of the important feature. The most important feature is the straightening of the left aorta border. Left aorta border will become straightening because the left atrial enlargement. So this is a prominent left atrial appendage. The white line you can see here, prominent left atrial appendage you can see here. Okay. And then the mitral valve calcification. So if there is a mitral valve calcification, you can make out the calcification. You have to draw a line from the costophrenic angle to the hilum. Okay. So from this side you have to draw it from the costophrenic angle to the hilum. If it is the aortic valve, it will be above that line, and if it's a mitral valve, it will be below that line, the calcification of the mitral valve. Then there will be the carina. This is the trachea divides into two. The carina will get widened because of the enlargement of the left atrial enlargement. The carina will become widened in the chest X-ray, and because of repeated hemoptysis, okay, so and pulmonary hemorrhages, so they can develop pulmonary hemosiderosis. Pulmonary hemosiderosis. So I have a X-ray of a pulmonary hemosiderosis. So I will show that later. Okay. So the left atrial enlargement is better visualized in right anterior oblique view. RAO, right anterior oblique view, is a better picture to depict the left atrial enlargement, students. Okay, right. And here this is a typical nice X-ray of a pulmonary hemosiderosis because of the repeated hemoptysis you can make out. Okay, this is a typical picture of the pulmonary hemosiderosis. Okay. Next, you should know indication of intervention in mitral stenosis, which is very important, students, which is very important. Okay, right. So here, so in a mitral stenosis, so it is classified into very severe MS, and progressive MS. Okay. So if the mitral valve area is more than 1.5 centimeter, it is a progressive MS. Severe MS is mitral valve area less than 1.5 centimeter. Very severe is less than 1 centimeter. So by pressure of time, if the pressure of time is more than 220 milliseconds, it is very severe MS. Severe MS is pressure of time more than 150 milliseconds. Progressive MS is pressure of time less than 150 milliseconds. What is pressure of time? It is the time which is required for the left atrial pressure to come to the half of its maximal pressure. So if the pressure of time is naturally, if it is more, the mitral stenosis is very severe. So it's a common sense, students. Okay. And there is a formula to find the mitral valve area by pressure of time. If the mitral valve area is equal to 220 divided by pressure of time, that is the formula to calculate the mitral valve area. So now you know very severe MS and progressive MS. The thing is whether it is severe MS or very severe MS, if they are symptomatic, it is classified as stage D. Stage D. In this, is the valve is morphology is pliable, if no clot, if no associated MR, then you go with a percutaneous mitral balloon commissurotomy. Okay, that is a class 1 indication. Suppose if both severe MS and very severe MS, if they are symptomatic, if the valves are not pliable, if there is associated MR or a clot, okay. So if it is there, then what you do is you will see whether there is a high surgical risk or not. If there is no high surgical risk, then you will do a mitral valve replacement. If there is a high surgical risk, in spite of not favorable valve, you will go with a percutaneous mitral balloon commissurotomy, but it is a class 2B indication at that time. In a very severe MS, if they are asymptomatic, even if they are asymptomatic in a very severe MS, if the valves are pliable, no LA clot or no MR, then you will go ahead with a percutaneous balloon mitral commissurotomy. But if the very severe MS if in a asymptomatic, which is also known as stage C, if the valves are not favorable, if there is a clot or associated MR, you will just do periodic monitoring, students. Okay, right. And in a severe MS, if they are asymptomatic, that is stage C, if they are asymptomatic, only if there is a new onset atrial fibrillation, if the valves are pliable, if no LA clot, no MR, then you will do a percutaneous mitral commissurotomy, or else you will just periodically monitor. If the valves are not favorable, if there is LA clot, you will just monitor, or if there is no AF, only if they are just asymptomatic severe MS, you will just monitor. In a progressive MS, if they are symptomatic, if the pulmonary capillary wedge pressure is more than 25 mm with the exercise, then only you will do percutaneous mitral commissurotomy, but it is a class 2B indication. So in a progressive MS, if the pulmonary capillary wedge pressure is not more than 25, then you will just do a periodic monitoring, students. Okay, students. So for a postgraduate level, this indication for surgery will be important. So you have to know about that. So next is we'll discuss few points about mitral regurgitation, the ECG, X-ray, and indication for surgery. Again, like in mitral stenosis, mitral regurgitation also left atria will get enlarged. Okay, X-ray also will show cardiomegaly, atria in atria. Okay, so here you can see the more than 120 millisecond, the left atrial hypertrophy. You can see here the left atrial hypertrophy. Okay, here you can see in the ECG. Next is the chest X-ray. Here you can again see the atria in atria. This is the left atrial margin, this is the right atrial margin. The atria in atria, the white shadow you can see here, the cardiomegaly. Then the indication for surgery in mitral regurgitation. Very important, students. Okay, very important. Okay, in a mitral regurgitation. So here primary MR, secondary MR. What is secondary MR? Secondary MR is because of cardiomyopathy or ischemic heart disease. It is a secondary MR. A primary MR is because of primary valvular pathology like rheumatic heart disease and all. Okay, right. So the MR is mainly classified into symptomatic, very severe symptomatic, that is stage D. Okay, asymptomatic severe MR is stage C. Okay, and then progressive MR is stage B, and then at risk still there is no MR, it is stage A. Okay, so in a primary MR, very severe MR, vena contracta more than 0.5. Vena contracta is the orifice of the jet where the velocity is maximal, but the size is very less at its origin, that is vena contracta. So if the vena contracta is more than 0.7 centimeter, if the regurgitation volume of the blood is more than 60 ml, if the regurgitation fraction is more than 50%, and the effective regurgitant orifice is more than 0.4, okay, then you will see symptomatic, it is stage D, and in the symptomatic severe MR, if the EF is more than 30%, okay, then you do mitral valve surgery, which is a class 1 indication. If EF is not more than 30, if it is less than 30, still you do mitral valve surgery, but it is a class 2B indication. Okay, students, right. So in a severe MR, if they are asymptomatic, it is divided into 3 stages. So if the LV end systolic diameter is more than 40 and EF is between 30 to 60%, mitral valve surgery is a class 1 indication. Whereas if EF is more than 60, if the left ventricular end systolic diameter is less than 40, okay, or in asymptomatic severe MR, if there is a new onset EF for a pulmonary artery systolic pressure more than 50, then you will see that hospital the performance. If the likelihood of successful repair in that hospital is more than 95% and expected mortality is less than 1%, then you do mitral valve repair, but it is a class 2A indication. Or else you will just do periodic monitoring in asymptomatic severe MR. In a progressive MR, where vena contracta is less than 0.7 centimeter, regurgitant volume less than 60, regurgitant fraction less than 50%, effective regurgitant orifice 0.4% less than, then you will just do periodic monitoring. In a secondary MR like cardiomyopathy or ischemic heart disease, you will treat coronary artery disease, you will do CRT therapy. If they are symptomatic, if they are having a heart failure symptoms, you do mitral valve surgery. If they are asymptomatic and a progressive MR, you will just do periodic monitoring, students. So these are the indications for surgery in mitral regurgitation. So a few points about the artificial valve you should know. Okay, students, like artificial valves, you have a bioprosthetic valve and a mechanical valve. Okay, mechanical valve, you have a tilting disc valve and a ball and cage valve. Bioprosthetic valves usually you put in old age people where anticoagulation is a risk more than 70 years. Younger people less than 65, you will put a mechanical valve. Bioprosthetic valve, another indication is a pregnancy where anticoagulation is contraindicated. So here this is a tilting disc valve. Okay, students, so this is the strut. Okay, and this is the disc. You can see the black one is the disc. This is a tilting disc. The tilting disc is St. Jude and George Shelley are the tilting disc, and Sri Chitra, our own Indian, is a tilting disc. So next is ball and cage valve. Okay, ball and cage valve is Stahl Edward is a ball and cage valve. Okay, so this is how the ball and cage valve will work. Okay, this is the ball you can make out. This is a suture ring. Okay, right. So tilting disc is always better compared to ball and cage because it can be attached into a smaller people with a smaller left ventricular cavity. Hemolysis is rare, and also the strut fracture is also very rare in a tilting disc valve, students. Okay, so this is about the discussion of the artificial valve. So what all these in these whole discussion of my the YouTube channel, the ECGs, X-rays, everything I have taken from Google and from the Harrison. So I acknowledge Harrison and Google for these things. Thank you, students.